Well, that's nature's way of actually stopping women bleeding, because when the same hormone which contracts the uterus is also important for ejecting milk. And there's this reflex, when the baby sucks, a reflex goes through the pituitary gland and the mother produces oxytocin. And it does two things. It causes the milk to come out, and it causes the uterus to contract. And if you speak to new mothers, they will say to you, every time I put the baby to the breast, I get a terrible contraction. But it's as I said, it's nature's way of doing it. So if you're at home and you've delivered at home and bleeding, then one of the best things you can do is get the baby to suckle, because that will cause the mother's own oxytocin. Because this oxytocin that we put up to contract the uterus is what she produces anyway, but we just give it in much higher doses. It's very rare, you know, it's terribly dramatic, but actually it's rare. But when it does happen, what effectively happens as you're delivering the placenta, it hasn't separated properly, and it pulls the uterus out with it, which literally goes inside out. And the woman drops her blood pressure, she usually collapses, she loses a lot of blood, and you actually haven't got much time.
Obviously, it is a major issue, and it is of great concern to people working in this field. There are a number of things that we can do at different levels to prevent women bleeding at the time of cesarean section. The one thing that we can do is identify those women who may have anemia. Anemia has been identified as one of the factors contributing to deaths from obstetric hemorrhage. So if we identify anemia in those women who come for antenatal care and treat the cause, and ensure that we give all women, all pregnant women, irrespective of whether they have anemia or do not have anemia, give them prophylactic iron therapy to ensure that when they come into labor at term, that their hemoglobin levels or their anemia is corrected. Women with accepted levels of hemoglobin are then less likely to suffer major complications if their hemoglobin levels are normal. So the one step is identify women with anemia, ensure that you give them prophylactic iron and folic acid, inform them why it is necessary to take these tablets, and ensure adherence to them taking the tablets. Also, you make sure that you not only do the hemoglobin level at the first booking visit, but repeat the hemoglobin level near term, around about 36 weeks of pregnancy, to ensure that the hemoglobin levels are normal. So that would be one step. The second step is to ensure that whenever you do a Caesar, that the Caesar is done for the correct indication. Make sure that the indication is appropriate, because all operations have complications, and certainly in poor countries, and even in rich countries, it is better to deliver normally than to deliver by cesarean section. Therefore, as I said, ensure that you have a proper indication for the Caesar. Ensuring a proper indication also implies that during labor you make use of the partogram to plot the progress of labor properly. Also ensure that you interpret the plotting of the various factors of labor so that you can come to a definite indication for the Caesar. So those are the important things to do. If, thirdly, you anticipate that the Caesar may be difficult, get the most experienced person in your hospital, the most experienced surgeon, to perform the Caesar. So that's quite important, because you are preparing yourself that complications might occur and that there is an experienced enough surgeon to deal with any complications that may occur. If you are in an hospital, and particularly a rural hospital, where there is staff shortage, you must ensure that the cesarean section is done by a single operator. A single person should not be giving the anesthesia and performing the surgery at the same time. So ensure that the operation is done by a single person and that there's another person giving the anesthetic and somebody else who is assisting. So we must ensure that there's single surgeon operators. If there is difficulty during the Caesar, always call for help from a more experienced person. If there's any delay in the single person coming, or in an experienced person coming, or there's no such person and you have to transfer the patient, make sure that you are prepared or know what to do in such circumstances. You may want to exteriorize or take the uterus out of the abdomen, and taking out the uterus from the abdomen decreases the amount of blood loss. You may want to apply abdominal aortic compression. There are other steps that one can do, but probably in a deep rural area where you have to transfer the patient, then you have to apply a uterine tourniquet. There is a diagram for this and a technique how to do this. The presenter of this lecture will show you a slide and take you through the application of a uterine tourniquet. Simply put, this is an application of a Foley catheter or a red rubber catheter at the base of the womb or the uterus. This is applied tightly. The abdomen and the vagina are then packed. The abdomen is closed and the patient transferred to another hospital. It is also used if you are waiting for an experienced surgeon or a specialist to come. There are advantages to doing this because it decreases the blood supply to the uterus. If you've had a difficult Caesar, you've managed to control the bleeding, also ensure that the patients who've had the difficult Caesar are kept in a high care area or in a specialized bed where they can be observed closely for some time. ensure that in such patients that an oxytocic infusion is given to the patient for at least 12 hours. So these are some of the kinds of measures that we can take to reduce bleeding, but those are the measures that we take ourselves, we as health professionals. The health educators, the medical schools and the health professionals council should ensure that all people doing seizures are well trained. Medical schools should train medical students about the anatomy of the uterus. Medical students should learn to assist at cesarean sections. When they become interns and when they become community service doctors, they must ensure that they have done sufficient number of seizures and be trained by specialists so that they can be prepared to do cesarean sections. So I think that those are the steps that we can take to reduce bleeding at the time of cesarean section and following delivery. So again, it's identifying the patients at risk, making sure that the indications for cesarean section are correct, ensuring that if you anticipate that the Caesar is going to be difficult, the most experienced person does the Caesar, that you ensure that if the Caesar is difficult, that you also know some of the basic means and techniques of stopping bleeding at the time of Caesar. Ensuring that patients who've had difficult Caesars are observed closely for at least 12 hours. Ensuring that during this time that oxytocin infusions are carried out, and the observations that you perform are carried out in a tool called a color-coded observation chart. The use of color-coded observation charts are useful in that they will identify the patients who are continually being at risk or who will become in danger of showing the signs of hypovolemic shock. Thank you for that question. I think it covers a number of different points. And it covers the issue of managers' responsibilities. Managers must ensure that their hospitals have the necessary equipment, have the necessary consumables, and have the necessary drugs. So in terms of hemorrhage, managers must ensure that there are sufficient oxytocic agents. Managers must ensure that there are the necessary intravenous fluids, and that there are always crystalloids available. Managers must also ensure that there are these specialized fridges for storing blood if there is no blood bank in that particular hospital. So all district hospitals which do cesarean sections must have this specialized fridge. But there's no point in having the fridge if there's no emergency blood kept in it. So the manager must ensure that there's somebody put in charge of the fridge to check on a regular basis the number of units that are supposed to be in the fridge, how many were used, and order blood to replace that stock. So how is this carried out? The manager can, if he or she does not have that fridge in hospital, can order the fridge or get one free from the South African National Blood Services. Secondly, the manager must appoint a nursing staff to be put in charge of the fridge and to check it in the morning and in the late afternoon, and check that it's working, that the temperature is correct, and obviously, essentially, that there's emergency blood available in that fridge. So, ensuring that there's fluid there, ensuring that there's emergency blood there, ensuring that the fridge and the ordering system for fluids and blood is working appropriately. Managers must also ensure that in the case of a dire emergency where there's no blood, that there's access to transport in which blood can be obtained in a short period of time. That the manager's staff, which are nurses and doctors, are trained to work as a team to deal with any emergency. That training can be in various forms. The manager must send, I believe, all his staff dealing in obstetrics to the training program called ESMO-E, which is Essential Steps in the Management of Obstetric Emergencies. This is a training program of 12 modules, and the modules that are relevant to your question is maternal resuscitation, in which health professionals are taught how to work in a team in resuscitating the patient. And secondly, managers must hold at least once a month a fire drill on maternal resuscitation or postpartum hemorrhage or other medical emergencies. This fire drill, which is called EOST, Emergency Obstetrics Simulation Training, is essential if we're going to maintain training and maintain our resuscitation skills throughout our careers. And managers' function, I believe, are that. That's the only way that we can ensure that bloods are supplied properly, and that we resuscitate patients properly who need it with appropriate fluids. Oxytocic drugs are quite essential because normally once you deliver a patient, the uterus will contract on its own with a release of endogenous oxytocin. But often the uterus does not contract, and we can't predict in which woman the uterus will not contract. Therefore, it is essential for us to use what is described as the active management of the third stage of labor, so that once the baby is delivered, you would use an oxytocic agent. The first line drug in South Africa is called oxytocin, or the trade name Syntocinon. This is available. It is on our essential drug list. And being on the essential drug list means that every hospital in South Africa can order that drug, because the government has decided that that is an essential drug. It is cheap, it is effective, and it can be given intramuscularly or intravenously. Therefore, our first line drug is oxytocin. If oxytocin does not work, or it is not ordered for your hospital, then the second line drug that we strongly recommend is either ergometrine or synthometrine. Ergometrine is an ergot product, and it is a very potent drug. It does have side effects, therefore it is our second line, and it is not used in patients who have hypertensive disorders of pregnancy or who have cardiac disease. So we recommend it as a second line drug. You may not have ergometrine in your hospital, but you might have synthometrine. Now, synthometrine is a combination of ergometrine plus syntocinon. This again is available on the essential drug list, the EDL, and it could be ordered for your hospital. So our first two drugs for making the uterus contract, or which are uterotonic drugs, are syntocinon and synthometrine or ergometrine. You might have read in the literature that misoprostol is used for postpartum hemorrhage. There is some debate about whether it is effective as oxytocin and synthometrine. Most people believe that the first line drug should be syntocinon, because there's more evidence for its use, and in our country we do have stocks of it, and we should be using it. Misoprostol might not be as effective as syntocinon for postpartum hemorrhage. However, if the syntocinon or synthometrine doesn't work, then you can use misoprostol. And some people use it rectally. So it's our third line drug. Our next line drug in South Africa is prostaglandin F2 alpha. This is usually used by doctors, and it's usually given in such instances directly into the myometrium or the muscles of the uterus. Now, these are the commonly used drugs that are available for use in South Africa. I would say that it is surprising that we still can't reduce the deaths from obstetric hemorrhage, because like anything in life, if you know what causes it, there are measures to overcome that. And we have measures in South Africa to overcome this. Therefore, we must follow the guidelines on postpartum hemorrhage produced by the National Department of Health. the National Department of Health also produces posters on how to deal with hemorrhage at caesarean section and after caesarean sections. These posters will be available for all hospitals in South Africa, and the presenter at this lecture will take you through the algorithms of bleeding at and after caesarean section. Okay.